Welcome all to the Provost Graduate Student Lecture Series. I'm Jacques Verberschot. I'm the chair of the committee. Normally I'm professor in physics and also graduate program director there. And we had quite a few proposals for these talks. In fact, I had a very hard time to select the best. And fortunately, Brian's proposal was one of the top ones of basically all members of the committee. And I'm very happy that you are giving this talk. Could I please ask Professor de Villa to introduce Brian, who knows everything about him?
I know everything about Brian. I am happy to be here to introduce Brian today. I have the pleasure and very good fortune to be his research mentor. Brian's a fifth-year doctoral candidate in clinical psychology. His research focuses on risk and protective factors related to psychopathology among sexual minorities. He's developed a coherent line of research in this area. He's already amassed 7 publications with 5 more under review. And he's attracted funding for his work from the National Science Foundation, the American Psychological Association, and the Society for the Psychological Study of Social Issues. Brian's currently working on his dissertation, which focuses on individual differences in how gay men cope with discrimination and how that relates to mental health. Today, Brian will be talking with you about his work in the area of lesbian, gay, and bisexual health. And so please join me in warmly welcoming Brian Feinstein.
Thank you, Joanne. Good afternoon, everybody. I'm happy to be here today to speak with you and to have this opportunity as part of the Provost Graduate Student Lecture Series to be here today. Just to give you a sense of what I'll be talking about today, I'm going to begin with a brief overview of what we already know from the empirical literature on sexual minorities and mental health. And then I'm going to describe a series of 3 studies that I've worked on, all related to this topic. The first study looks at how specifically discrimination influences mental health in a sexual minority sample. And the second and third studies focus on protective factors for mental health problems subsequent to discrimination in sexual minorities. So specifically looking at parental acceptance and also at romantic relationship involvement. And at the end, I'll leave time to answer any questions. So in beginning, I want to draw your attention to some data from the National Survey of Midlife Development, which demonstrates how sexual minorities are at increased risk for a host of psychiatric disorders. So this sample is a sample of about 1,300 men here, and as you can see, they have higher rates of major depression, generalized anxiety disorder, and panic disorder, and they also are more likely than heterosexuals to have at least one disorder or 2 or more disorders. And when looking at women in this sample, you see the same trend where they have higher rates of both depression and anxiety disorders, and they're more likely than their heterosexual counterparts to have either 1 or 2 or more disorders. Now, this finding of sexual orientation-related health disparities in the area of mental health is quite robust and has been demonstrated across a series of population-based studies, again and again showing this increased risk among lesbian, gay, and bisexual individuals for depression and anxiety disorders. And this extends to other forms of psychopathology, including alcohol use disorders, tobacco, and other drug use. Notably, these disparities begin to emerge in youth and adolescence, and they're seen in young adults as well, suggesting that not only are sexual minorities at increased risk for mental health problems, but these differences begin to emerge relatively early in the lifespan and persist across development. In a meta-analysis of studies on sexual orientation and mental health, Alon Meyer found that in aggregating the work in this area, that sexual minorities were 2.5 times at increased risk for a lifetime history of a mental disorder compared to heterosexuals, and they were 2 times at greater risk compared to heterosexuals to have a current mental disorder. So altogether, this provides a clear picture that sexual minorities are in fact at increased risk for mental health problems, which leads us to the question of why that is. Now, the leading theory in setting up a framework for why sexual minorities are at increased risk for mental health problems is Alon Meyer's minority stress theory. And I'll direct your attention to several aspects of his theory, starting with the notion that all of this begins because of the fact that sexual minorities are at a disadvantaged social status in our current society. So because of their minority status, sexual minorities are likely to experience a host of stressors that contribute to their increased risk for psychopathology. So these stressors include stressors in the general environment related to discrimination and prejudice. And they also refer to stressful experiences that are more internal to the individual. So two that I'm going to be talking about specifically today are internalized homophobia, which refers to an individual's internalization of negative attitudes in society toward non-heterosexual identities, attractions, or behaviors, as well as expectations of rejection. So this is also often referred to as rejection sensitivity, and this construct represents an individual's anxious expectation that he or she is going to be rejected by others because of their sexual orientation. And together, these additional stressors, or these unique stressors that sexual minorities experience, in addition to more general life stressors that anybody could experience, contribute to or account for their increased risk for mental health problems. Now, unfortunately, discrimination is a relatively prevalent phenomenon among sexual minorities, even in the changing social climate that we live in today. Data from a nationally representative sample of sexual minorities indicated that approximately 50% of the sample had experienced verbal abuse of some sort, about 23% experienced threats of physical violence, and 13 to 15% experienced either physical violence or property crime. In a meta-analysis on this area of work across 138 studies, it was demonstrated that approximately 41% of sexual minorities experience some sort of discrimination related to their sexuality. And this meta-analysis aggregated the work across a sample of a total of 60,000 participants, suggesting that it is, in fact, quite a robust phenomenon. And consistently, research has demonstrated that discrimination against sexual minorities is related to mental health problems like depression and anxiety. Now, the one area that the minority stress framework doesn't particularly address is how specifically discrimination comes to influence mental health. So, although an individual can experience discrimination, that doesn't necessarily mean that they're going to develop mental health problems. And Mark Katzenbuehler extended this theory with his psychological mediation framework to try to get at what's happening, what processes are underlying this association between discrimination and mental health. So he proposed that objective events of discrimination or violence lead an individual to experience these more internal processes that I described before, like internalized homophobia or expectations of rejection, as well as additional, more general psychological processes like maladaptive coping and maladaptive emotion regulation, and that it's through these specific processes that discrimination contributes to mental health outcomes. So what I was interested in looking at in this first study was whether or not internalized homophobia and rejection sensitivity do, in fact, mediate the associations between discrimination and symptoms. So in other words, I was interested in testing whether these two internal processes were mechanisms through which discrimination influenced mental health among sexual minorities. And I was also interested in looking at whether or not there were gender differences in how these processes operated. So my colleagues and I conducted a survey study of approximately 500 lesbians and gay men. Approximately 50% of the sample was female, and the average age was in the early 30s. This was predominantly a Caucasian sample, and as I said, they completed an online survey that included measures of various constructs, including gender nonconformity in childhood, discrimination, internalized homophobia, rejection sensitivity, depression symptoms, and social anxiety symptoms. I'm not going to go into detail about the measures, but I'm happy to answer any questions about those later. So we tested a path model wherein we wanted to see if, in fact, internalized homophobia and rejection sensitivity did act as mediators in the relationship between discrimination and mental health symptoms. We found that based on fit indices, the model represented and fit the data quite well. suggesting that discrimination does in fact have an influence on depressive symptoms and social anxiety symptoms, and that these associations are mediated through internalized homophobia and rejection sensitivity. So approximately 28% of the variance in depression was accounted for by this model, and 11% of the variance in social anxiety symptoms. And bootstrapping analyses indicated that these mediation findings were significant. So it does appear that both of these internal processes, these negative thoughts and feelings about one's sexual orientation, are the driving factors underlying, or two of the driving factors underlying the relationship between discrimination and mental health problems. We also found that childhood gender nonconformity acted as an antecedent to discrimination, suggesting that men who were more feminine during childhood and women who were more masculine during childhood experienced greater discrimination, setting this process to unfold. When we tested gender differences to see if this model fit differently for lesbians versus gay men, we found that there were not significant gender differences, suggesting that these processes operate similarly for both genders. So a few take-home messages from this particular study. First, we see that consistent with both minority stress theory and Mark Katzenbuehler's extension of this theory, two of the ways in which discrimination influences mental health is through influencing an individual's thoughts and feelings about his or her sexual orientation. So it's not just that discrimination automatically means that an individual is going to experience mental health problems, but to the extent that somebody experiences more negative thoughts about their sexual orientation, more negative feelings about it, to the extent that they expect to be rejected by others in other social situations because of their sexual orientation, they're going to be that much more likely to experience depression and social anxiety symptoms. We also see that these processes operate similarly for lesbians and gay men, and this was of particular interest given that there have been several findings looking at specific aspects of the minority stress process that have demonstrated differences as a function of gender. So generally speaking, sexual minority males experience higher rates of discrimination and violence compared to sexual minority females. Yet when looking at how these processes operate together and how discrimination influences mental health, it seems to be similar for both genders. So one of the most important points to take away from this is that although discrimination is largely out of an individual's control, the way that they think and the way that they feel is not necessarily out of their control. So this has important implications for mental health practitioners and for interventions designed to help sexual minorities in coping with discrimination and dealing with some of their negative feelings that they might have related to their sexual orientation. So currently there are investigators in the field who are developing interventions that specifically target these aspects of minority stress in an effort to adapt current empirically supported treatments for depression and anxiety to deal with the specific stressors that sexual minorities experience. And also, clinicians who are generally affirmative of sexual minorities can provide corrective learning experiences that can counteract expectations of rejection. So for sexual minorities who may enter therapy with an expectation that they're going to be rejected, perhaps which came to be because of discrimination that they experienced in other situations, or just the general knowledge that there is this stigma surrounding non-heterosexual identities, having a clinician who's affirmative of sexual minorities and who is supportive could act as a different experience for the individual to hopefully act as a catalyst for change for that person and lead them to be less likely to expect rejection in the future. So coming back to minority stress theory, the study that I just described highlights how some of the ways in which discrimination influences mental health. But another piece of minority stress theory is that Meyer suggested that coping and social support resources may moderate or attenuate the relationship between discrimination and mental health. So although discrimination might lead to mental health problems for certain sexual minorities, this might not be the case for all sexual minorities. So an important area of research that's recently gained more attention is looking at protective factors that contribute to resiliency in this population. So trying to figure out whether or not there are subgroups of sexual minorities who, in the face of discrimination, are protected against negative outcomes. One area that my colleagues and I were particularly interested in looking at was family relationships. Family relationships are certainly important to everybody, but they may be particularly important to sexual minorities, given that many sexual minorities experience difficult family relationships throughout their life. For instance, parents often respond negatively to the initial disclosure that their child is a sexual minority. Sexual minorities tend to report lower levels of parental support compared to heterosexuals, both in adolescence as well as in young adulthood. And we know that these factors, having more accepting parents and having more family support, are associated with improved well-being in sexual minorities and in general. So given the importance of family relationships and the fact that many sexual minorities have challenged family relationships, my colleagues and I were interested in looking at whether or not parental acceptance and family support would moderate the associations between different aspects of minority stress and depressive symptoms. We were interested in looking at both family acceptance of one's sexual orientation and also a more general construct of family support for a particular reason. One study had recently demonstrated that social support specific to issues related to sexuality was related to less distress among sexual minorities, but that this wasn't the case for more general social support. This is consistent with a theory known as the matching theory of social support, suggesting that the support that an individual experiences needs to be in the same domain or a consistent domain with the stress that they experience in order for it to act as a stress buffer and protect against negative outcomes. So using data from the same study and same sample that I described before, we were looking at a couple additional measures. So we were looking at parental acceptance, which was asked by two questions: how tolerant is one's mother or closest female guardian, and how tolerant is one's father or closest male guardian of one's sexual orientation currently. And participants could indicate anywhere on a 1 to 7 scale how tolerant their parents were, ranging from completely tolerant and accepting to completely hostile and rejecting. And then we also measured more general family support using 4 items from the multidimensional scale of social support. And items were, for example, asked things like, I get emotional support that I need from my family, and were rated on a 1 to 5 scale for how much the person agrees with that. So first, just looking at the basic correlations between both parental acceptance and family support and these aspects of minority stress and depression. In yellow, you see that there were significant associations between parental acceptance of one's sexual orientation and all 3 dimensions of minority stress, as well as depressive symptoms. So for those sexual minorities who reported higher levels of parental acceptance, they also reported less stress, both external in terms of discrimination, as well as less internalized homophobia and less expectations of rejection. And they also reported lower depressive symptoms. We found consistent with this that those who reported higher family support also reported lower levels of discrimination and rejection sensitivity, as well as lower levels of depressive symptoms. So in general, we see that parental acceptance of one's sexual orientation and family support appear to generally be related to minority stress and depression in the ways that we would predict. So next, we were interested in looking at our main questions, which were whether or not these 2 aspects of family support moderated the relationships between minority stress and depressive symptoms. So to do this, we conducted a series of linear regressions, entering the interaction between our moderator variables of interest and our predictor variables in predicting depression. And as highlighted in yellow, we had significant interactions between parental acceptance and internalized homophobia, as well as parental acceptance and rejection sensitivity in predicting depression. In contrast, we did not see a significant interaction between parental acceptance and discrimination. When we looked further into these interactions, we saw that for those sexual minorities who reported less accepting parental attitudes, internalized homophobia and rejection sensitivity were both associated significantly with higher levels of depressive symptoms. In contrast, for those who reported more accepting parental attitudes toward their sexual orientation, these aspects of stress were not associated with depressive symptoms. So here we see that having accepting parents who are accepting of one's sexual orientation appears to reduce the association between both internalized homophobia and depressive symptoms, as well as rejection sensitivity and depressive symptoms. In contrast, we didn't find this effect for external discrimination, nor did we find it at all for general family support. So to take away from this study, it appears that negative thoughts and feelings about one's sexual orientation were associated with depressive symptoms, but only for those who reported lower levels of parental acceptance. However, we saw some specificity for this effect, where we saw the stress buffering effect for both internalized homophobia and rejection sensitivity, but not for discrimination. So it's possible that the knowledge that one's parents accept their sexual orientation might not be enough, might not have a strong enough benefit to really reduce the association or the negative impact of discrimination on one's mental health. When somebody's faced with clear, explicit evidence that somebody in their social environment has, takes offense to them or has a problem with them, then just knowing that your parents are accepting of you may not be enough. In contrast to that, if somebody's struggling with their own thoughts and feelings about their sexual orientation and their expectations that they might be rejected by others, those internal processes may be likely to be buffered by parental acceptance of one's sexual orientation. Now, the fact that minority stress was associated with depressive symptoms, regardless of the extent to which sexual minorities experienced more general support from their families, is consistent with the social support matching theory that I was describing before. So it was only when the type of social support in question was in the domain, which is surrounding sexual orientation, that it acted as a stress buffer. In contrast, having parents who are generally supportive, while that's certainly a good thing, was not enough to protect individuals from depressive symptoms in the face of minority stress. So one thing that this suggests is that while certainly encouraging parents to be supportive of their sexual minority children is hugely important, it's particularly important to emphasize and underscore the impact of accepting their sexual orientation specifically over and above the general impact of providing emotional support for them. So these two studies are certainly limited in several ways, including relying on cross-sectional data, having limited ethnic racial diversity, not including bisexual individuals, and not assessing all components of the psychological mediation framework that I described before. So in this third study that I'm going to present, my colleagues and I were interested in remedying some of these limitations and also seeing if this stress buffering effect that we found extends to romantic relationship involvement as well as family support. So we know that romantic relationships are a major source of support for individuals, particularly adults, which is a time period in individuals' lives when the support of their partner is often their primary support that they receive. We also have a wealth of data to support the idea that being in a satisfying romantic relationship is generally associated with improved well-being and positive health outcomes. Notably, one study found that being married reduced the associations between discrimination and both physical symptoms and symptoms of disability among Mexican Americans. The author suggested that having the support of one's partner, being able to rely on one's partner, talk about what they experience with their partner, may have been helpful in reducing the impact that discrimination had on these individuals. So in this third study that I'm going to describe, we were interested in seeing if this extended to sexual minorities and seeing whether or not romantic relationship involvement buffered the associations between discrimination and victimization and depressive and anxiety disorders among sexual minorities. So for this study, we used data from Wave 2 of the National Epidemiologic Survey on Alcohol and Related Conditions. The NESARC dataset is a nationally representative study looking at approximately 35,000 individuals in the US. And we used Wave 2's data because this is when they first introduced questions about sexual orientation. There are a total of 577 individuals who identify as lesbian, gay, or bisexual in this sample. So we focused our analyses on this subset of the overall sample. Approximately 53% of our sample was female, and it was approximately half and half in terms of identifying as lesbian or gay versus bisexual. The mean age for the sample was approximately 43, and although a large number identified as Caucasian or white, there was a fair amount of variability in race and ethnicity. So first, participants were asked about their relationship status over the past 12 months, and they were asked if they were married, dating, or involved in a romantic relationship in the past year. 366 were involved in a relationship, and 211 were not. And then they were also assessed using the Alcohol Use Disorder and Associated Disabilities Interview, which is a structured diagnostic interview used to assess and diagnose aspects of alcohol use disorders as well as other psychiatric disorders, including depression and anxiety disorders. So we focused our analyses on both depressive disorders and anxiety disorders. Here, depressive disorders refers to either major depression or dysthymia, and anxiety disorders was a composite category referring to any possible anxiety disorder like post-traumatic stress disorder, social phobia, specific phobia, panic disorder, or agoraphobia. And we also had a third variable that we looked at, which was a composite of any depressive or anxiety disorder at all. Participants were asked about whether or not, to what extent they'd experienced discrimination in 4 different areas. They were asked before the past year, how often did you experience discrimination because you were assumed to be gay, lesbian, or bisexual? And these 4 areas included one's ability to obtain health care or health insurance, when receiving health care, in public, such as on the streets or in stores or restaurants, and in any other situations. For example, obtaining a job, on a job, or getting admitted to school or a training program. Participants were also asked whether, before the past year, how often they experienced victimization, such as being called names, or being made fun of, picked on, pushed, shoved, hit, or threatened with harm because they were assumed to be gay, lesbian, or bisexual. Participants could respond with several different options, including never, almost never, sometimes, fairly often, and very often. And we coded those individuals who indicated that they had never or almost never experienced an item of discrimination or victimization as a 0, as though they had not experienced it. And anyone who had experienced something either sometimes, fairly often, or very often was coded as having had experienced that event. Then we created sums for the number of discrimination items that somebody experienced. So someone could endorse a total of anywhere between 0 and 4 items for discrimination, and anywhere between 0 and 2 items for victimization. So I want to draw your attention first to the yellow cells. We ran a series of regressions, first in an unadjusted model, and then second in an adjusted model where we took into account sex, race, ethnicity, and age to control for those factors. And we see first, contrary to what we would have expected, that relationship status was associated with increased odds of having an anxiety disorder or having either a depressive or anxiety disorder. Now, this was initially surprising given that there is such good data looking at the association between being in a relationship and more positive health outcomes. On second thought, we realized that the measure of relationship status in the NESARC study is relatively vague, and it asks about a host of different relationships, like whether someone's dating or married, and it doesn't assess the quality of the relationship that the person is in. So we also know that being in a dissatisfying romantic relationship is associated with various aspects of psychopathology, including depression and anxiety. So it's possible that here we are combining people by virtue of the study design and the data that we had, who had experienced both healthy, adaptive, positive relationships and less healthy, more dissatisfied relationships. Consistent with what we expected, we did see that both discrimination and victimization were associated with increased odds of anxiety disorders as well as depressive or anxiety disorders. And we saw that relationship status was also associated with an increase in discrimination. Now, there are 2 possibilities for why this might be. On the one hand, some of the discrimination items referred specifically to healthcare coverage, and it's possible that given that healthcare coverage is not universally applied to partners of individuals in same-sex relationships, it's possible that people in relationships were in fact experiencing discrimination related to healthcare. And it's also possible that being in a romantic relationship, being seen out in public with one's partner, could draw negative attention toward an individual. So then we got to our main question of interest, which was looking at whether or not relationship status acted as a stress buffer, reducing the associations between discrimination and victimization and diagnoses. And we see that relationship status did in fact moderate the association between discrimination and diagnoses. In the yellow cells, you see that discrimination predicted an increased odds of having an anxiety disorder or having either a depressive or anxiety disorder for sexual minorities who were single, but it did not predict significantly for individuals who were in relationships. So this finding suggests that for sexual minorities who are single, discrimination does appear to relate to having increased odds of being diagnosed with a depressive or anxiety disorder. In contrast, this relationship seems to dissipate for those individuals who over the past 12 months have been involved in a romantic relationship. In contrast to these findings, we did not find that romantic relationship involvement moderated the associations between victimization and diagnoses. So there appears to be some specificity here in the types of minority stress for which relationship involvement might serve as a stress buffer. And there are a couple possibilities for why this might be. One possibility is that the items of discrimination that were included in NESARC's design asked participants to indicate how often they had experienced discrimination in several different situations. It's possible that these situations could have been relatively ambiguous and the individual may have perceived discrimination. For instance, one of the items for discrimination asked whether or not participants had experienced discrimination when at a restaurant. It's possible that if you had a sexual minority individual who was at a restaurant, if he or she was receiving poor service, he or she might attribute that poor service to their sexual orientation, when in fact it may not have anything to do with that, and it could have everything to do with the server or the circumstances. So in this case, it's possible that some of the discrimination items referred to more ambiguous, less explicit aspects of discrimination. In contrast, the harassment items were pretty clear in terms of what they were assessing. So the harassment items asked to what extent people had been subject to verbal harassment, to being kicked, pushed, shoved, etc., which are instances that are less likely to be left open for interpretation. Another possibility is that these different items for discrimination and victimization represent different levels of severity of violence or of discrimination. So the harassment items could be interpreted by the individual as being more severe in that they often involve physical altercations and otherwise explicit verbal altercations, whereas the discrimination items may not involve human interactions at all. They may simply have to do with policies related to one's relationship status. So while it's noteworthy that relationship status does appear to moderate the associations between discrimination and psychiatric diagnoses, it'll be important for future research to try to get a better understanding of what specifically is happening here and why we're seeing differences between different aspects of minority stress. Now, this research, I think, generally has the important implication of romantic relationships having the potential to reduce mental health disparities between heterosexuals and sexual minorities. So as discussed before, there's clear evidence that sexual minorities are at increased risk for mental health problems, and that also extends to several areas of physical health as well. And seeing that romantic relationships in general, or that romantic relationships can reduce or buffer the associations between stress and mental health problems suggests that it's possible that promoting healthy romantic relationships among sexual minorities could have a larger impact on reducing, to some extent, these disparities in mental health that we see. And on a related note, this sort of research is increasing and is particularly important given that same-sex marriage policies have been shown to have an impact on sexual minorities' health. So there have been several studies that have been done using data collected both before and after the passing of certain laws, marriage equality laws, seeing that the repeal of certain laws that prohibited same-sex marriage was associated with decreases in mental health problems. So altogether, this area of research suggests that relationship involvement has the potential to really benefit health in quite strong ways. Now, this study using NESARC has certainly some limitations. These data are cross-sectional, although the third wave of NESARC's data has recently come out, so it's possible that we'll be able to soon look at the extent to which these relationships can also be demonstrated across longitudinal data. And as noted, our assessment of discrimination and victimization is limited. It only assesses a select number, in this case 6, different types of discrimination and victimization. And there are certainly aspects of discrimination, victimization, and violence more generally speaking that could also be experienced by sexual minorities. And as noted, that the assessment of relationship status was also not particularly specific, so it's not clear to what extent participants in relationships were in healthy relationships or dissatisfying ones. So I just want to make a few concluding remarks. In general, this research suggests that sexual minorities are at increased risk for mental health problems, in part due to the unique stressors that they experience related to their disadvantaged social status. That one of the ways that discrimination influences mental health in this population is by increasing negative thoughts and feelings about one's sexual orientation and increasing expectations that one will be rejected in the future. And that there are factors that have been identified that could protect sexual minorities from mental health problems subsequent to discrimination. So in particular, parental acceptance of one's sexual orientation and romantic relationship involvement have the potential to contribute to resiliency in this population. So in concluding, I would like to thank all of my collaborators on these 3 studies, as well as the National Science Foundation for the funding to do this work.